Because patients come to see me if they have ulcers. That's a significant problem. If you can't heal these ulcers of your fingers, then the angiogram always shows something. So the angiogram's too late sometimes too. Yeah. Yes?
If you know that the collateral vessels are already occluded with collagen junk, is there anything else you can do with lower extremities?
You mean to the foot?
Yeah.
Some of my colleagues have done sympathectomies for the foot. Yeah, they have. They have. It's a dicey thing because it takes so long to heal. You're off your foot for a couple of months.
What they told me was all the other, the smaller collateral ones are already filled up with junk. So can you
You would start with an angiogram to the foot. Similarly to the hand, you get an angiogram and see what the blood vessels look like. Yeah. Is that a major problem for feet? Are feet as much of a problem as hands for people? Yeah. Yes?
I'm a little curious about the role of pathogens, if any, in ulcers. I would assume that the reason that people don't have ulcers when the blood flow is better is because there's more oxygen getting into the fingers and they stay free of pathogens.
Absolutely. Absolutely. I mean, in bacteria.
Yes.
Yeah, absolutely. So with an ulcer, right? So things that other people do, just you injure your fingertips all the time. Okay? So things that you do with your fingertips, people usually heal. There's bacteria in all your fingertips. Okay? So you have decreased blood flow. It just sets the advantage up for the bacteria and for the poor healing. And things don't heal. So bacteria definitely don't help. So what do we tell patients? We tell them to keep it clean, as well as to keep changes in the dressings and to kind of keep your hand warm, just to kind of maximize that. When we debride an ulcer in the operating room, a lot of times we'll go and we'll find really just poor bone, and that means the bacteria has gotten into the bone, osteomyelitis. So at the same time we release it, we go in and we nibble away all the dead bone because we need to get rid of as much bacteria as possible. And then things generally heal. Yes?
Does poor blood flow impinge on nail growth?
No. Well, I mean, the speed of growth?
I ask because if someone had asked me to, I just got my first digital ulcer. I've had Scleroderma for about 15 years. So I could have said 5 to 7 years ago, that finger is going to be problematic. It felt different.
Yeah.
It was different, and the nail would never grow. I've got good long nails. It would always break. It was always different from all the other fingers.
Absolutely, yeah. In that sense, yes. It's kind of, again, back to the tree analogy. If just the blood flow brings nutrition, and it's like good soil there. So that tree's not going to grow as well because it's starving for oxygen. So the nail's not going to grow as well either. Absolutely. So you knew that finger was a problem. Exactly, exactly.
Some of us have really soft voices and we can't hear questions out, so we're going to...
I can make sure you all hear what I have to say. I have 3 quick questions. One is the angiogram. Can you do that without contrast for somebody who's allergic? Is there a way to be able to visualize at the level you need to without contrast?
Generally that specific angiogram, you need contrast. In that case, what we do is an MR angio. It's not as good, but it usually gives me enough information. An MR angio uses gadolinium, a different type of dye. It's not even the same thing. Right, would you agree?
So, yeah, they do that. You can do a CT again, but you need contrast. Usually, and then your analogy to that's a problem. But with gadolinium, there's no long-term sequelae or complications. And certainly, you can do that. That's an alternative. It's not as good as the gold standard, as you mentioned. The plastic angiogram is always better.
Yeah, that's exactly right. I want some roadmap to the hand. And so obviously if you have a contrast allergy, we don't want to do anything that's going to affect your kidneys or anything, then we do an MR angio.
The other one is, what about in a different area? For the contractures, have you had any luck using cortisone injections at all at the base of the fingers?
Not really.
No.
Not really, because usually the contractions are so fixed. Sometimes our therapists tell you about some gentle stretching, but there's no quick fix to those joints.
Okay, and the final question is, when you're going in for the sympathectomy, and sorry to jump all over the place.
No, that's fine. That's,
When you're going in for the sympathectomy and you're teasing back all of the additional collagen and the nerves, you're not moving the nerves off of the structure of the
we are. We're actually cutting it off.
So when you have surgery, your nerves all grow back. Did that happen then in your hand? Your nerves grow back towards the vessel?
We don't know. We don't know. But hopefully, it's like a wiring system. We disconnect the wiring. Hopefully, it won't be smart enough to connect in that same way. But we really don't know.
And the nerves, so what the theory or proven is that the nerves connected to the blood vessel is what's sending the signal to the body to form collagen in that area?
No, two different things. That's just that controls the diameter of the blood vessel. The nerves cause the blood vessels to constrict or to relax. And we say there's too much constriction. So it's like unplugging a cord to something that's causing a constriction. Okay? The collagen forms on its own as part of the disease process. You're welcome.
Hi, thank you for today's lecture. I just have a couple of questions. The first one is when you have the small blood vessels of the fingertips decreasing or disappearing, do you still recommend staying on flodipine?
Staying on what?
On flodipine, the calcium channel blockers. And then the other question has to do with, as you mentioned earlier in the presentation about people who use jackhammers and how it affects the vascular system. Have there been any studies, and do you have any recommendations or opinions on typing, which a lot of us use keyboards now, the trauma to the fingertips, and also the weight bearing, even though it's light weight bearing, of our wrist with the ulnar radial arteries?
Okay, the first question was, is it worth staying on nifedipine if you feel that one of the blood vessels is clotted off? Yes, because you got to worry about all those other fingers too. And we don't really know what happens at a micro level. So it may be enough that you're going to get some collateral circulation. There's little blood vessels in the back of the finger too that get there also. So by all means, if you can tolerate the nifedipine, I would stay on that. The second question on what happens with the fingertips. That's a hard thing for patients with scleroderma because you're doing micro trauma to the tips of your fingers all the time. It was worse in the old days with typewriters because you actually had to whack on them. But still, it's very hard. I think our therapist will spend some time this afternoon talking about tender, loving care for your hands and how to kind of really adapt different things to do this, because your hands you want your hands your whole life, and that's so the investment on taking care of your hands. I present a surgery which is kind of not the last resort, but a big heavy hammer, but it's really that gentle care every day that's going to make it better to prevent ulcers.
Have you found decrease? I'm sorry. Have you found in your studies that type of light trauma, even though it's light trauma to the fingertips, is accelerating?
There are no studies that prove that one way or the other, because no one's tracked 100 patients with scleroderma, and one's a type and one's a don't type. But just by common sense, I think that's an issue that we all should pay attention to. These are the areas that are going to ulcerate, the fingertips, the end of the line. So that repetitive trauma can be, a bad thing.
Just one quick comment on that. It's just, when you go to open like even a sour cream container, it's just one little push and you don't realize it for days, all of a sudden something comes up.
That's right.
It's not even repeated. It can be one thing you do and you see it, 2 weeks later, up comes the ulcer and there it is.
Absolutely. Yeah.
If you're right-handed or left-handed, is it the hand that you use the most, the one that's affected with Raynaud's the most?
We don't see a difference because the anatomy may be a little bit different on either side. We don't know which finger gets an ulcer. I've seen index, middle, ring. Yeah. Sorry? I've had patients on the non-dominant hand also. Sometimes one hand, the more you use your hand, the hand may hurt more because when you're using your hand, you're having more activity to your hand. So each muscle is doing more, so it's using up more oxygen. So it may feel like it hurts more. Do people notice that? Their dominant hand hurts more? Some do, some don't, yeah.
Well, mine's wider, mine's dominant.
Is that right?
Wider
Hi.
Hi.
I have systemic scleroderma, but I've noticed like the first I've diagnosed 2 years ago. So the first 6 months, my thumb and finger, the pointer finger, and on both hands, everything was very painful. But I've noticed that I don't have any ulcers at this point. I did start a calcium channel blocker, which is helping my Raynaud's attack not be so extreme. I've only had Raynaud's for 1 year, a little over a year. But now I'm recognizing that now it's going to my third finger, deformation of the fingernail, the clubbing, the clubbing, the roundness of the fingertips. And I know you're saying maybe you're doing the operations late. My whole curiosity is I would maybe be, interested in talking to you about if I do risk getting an operation now where I know I'm healing. I don't have the calcium deposits. I don't have the complications that a lot of my friends have, but is that a worth a risk to get this operation done because I am healthier now than I would be? Hopefully I don't get to that point, but is it more preventative?
You're exactly the type of patient that keeps me up at night thinking about this. Because you're not having, it's hard to go through all the surgery at a point where you're doing really pretty well. And so, do you have pain? Do you have
and the thing is, I've noticed just from having this disease, I had no idea what my threshold would be with pain. So before I had to be on some painkiller just a few times a month only because I couldn't bear it anymore. But I'm a type of person that would rather not take painkillers because it messes up your stomach, blah, blah, blah. Yeah. So I'm very proactive. I do yoga. I'm actually investing because the insurance doesn't pay for my body massage, but I could, after 6 months of body massage twice a week, I'm pinching my neck. I'm pinching my arms, my skin on my back of my legs and back. Phenomenal difference. Mm-hmm. I mean, it's amazing. But what's frustrating is that insurance won't cover it. And again, I'm all about preventative. I'm off of my anti-inflammatories. I've done acupunctures, a lot of other things. But the massage and yoga, the biofeedback from that has really helped. But then again, I'm interested of preventing problems 5, 10, 15 years from now.
So if you're in my office, I'd say the downside of operating is the risks of surgery, the time off of work, the amount of therapy it takes to kind of get your hand back, the pain of surgery, the risk of being in a hospital with infections and everything. Okay, and are you operating too early? Are you going to have something done 10 years down the road or something? The benefit of surgery is if you can get off the pain medication, if you can prevent things from getting worse, if, God forbid, you have to move or change your whole lifestyle for that. So that's where the two sides weigh on each other.
And I appreciate that, but at the same time, I've gone through the pain for that first year and a half, that to heal, I feel more confident now that I would heal now better than if I had You mean heal here?
Yeah. I have no doubt you'll heal this fine. Some patients have a little wound that heals, but all the patients have healed over time. A little area opens up and it'll heal. This is a good area to heal. Mm-hmm. If you don't have any ulcers, you're not going to have any trouble healing this.
Okay.
So you may wait until you have a really first ulcer or poor finger or pain. I don't know.
Yeah. I guess I just don't want to reach that pain.
Some patients
I'm wondering to risk, and I guess I think mentally I could tolerate going in, being proactive and saying, I know I'm going to have this operation. I know I'm preparing mentally that it would be painful. I know the risks. Yeah. I think right now I'd rather take that risk now because I feel good versus waiting for it to happen.
Here's the other key point is maybe an angiogram would be a reasonable first start, because if I find that you have one area that the blood vessel's clotted off, but both ends are still open, those are the patients that do so well because I can put a vein graft across there and it'll keep flowing. If the blood vessel is okay proximally but it's clotted off and the end is all clotted off, I have nothing to plug into, those are the patients I really feel like, God, I wish I came earlier. So sometimes an angiogram, if it shows a discrete defect, that one of the patients I showed you with the bypass, she's great because you're getting more blood flow, and the higher pressure head, I think, will prevent things from clotting off distally too. So you're welcome.
I have a question. This kind of follows that up. The clubbing of the fingertips, that can be lung-related and oxygen-related.
Yeah.
How does that play into it? So if she's getting some clubbing, is it possible, like if it's from oxygen, would it be all your fingertips, or could it still be just a few?
Again, if I had a crystal ball and look at your angiogram, I bet you have less blood flow to your index finger and middle finger, where you were the one you felt decreased flow, right? To those. Yeah. Yeah. Yeah.
But it's in the nail bed, feels like
Yeah.
although it's there.
So clubbing can happen to any finger, but it's going to be worse in the fingers that have decreased flow in the hand here in this. Yes.
3 questions. You mentioned about keep hand warm. So Bay Area is quite cold. If you move to Arizona or San Diego, do you think that would help? And number
Okay,
2.
let's one question at a time. I'll answer each one.
okay.
Just be easier. I had 2 patients who moved to San Diego and felt it helped. Because, I mean, she was a young woman who just, it changed her life in some way. You moved to Fresno. Yeah. So, you know, if you live in the Bay Area and love it here, then you have to find other ways to adapt, you know, glove warmers and everything. But it does get cold here in the mornings, especially if people live in Marin and everything, or in the city.
Okay, and the second question is that for the calcified joint at the shoulder area, is the surgery the only solution? Because I heard something like acupuncture or exercise, sometimes that could help.
I don't know much about acupuncture, but for exercise, patients who have shoulder tightness may benefit very well from physical therapy because it's a big joint that can stretch out. So I would definitely recommend you undergo a trial of physical therapy for that.
Okay. And the third question, that if you use walking cane, I noticed that hand become very painful and very weak. Is there something can be done about that?
I don't understand why you're weak. Is it your legs or your hand, or what part is weak?
Imbalance, because I tend to fall. So doctor want me to use a cane, a walker.
Well, that's probably not your hand, but something else more central that I'm not an expert on, so I don't know.
But it causes the hand to become very painful.
Oh, is that right? Maybe sometimes when you're gripping something like that all the time, what are you doing when you're gripping? It's not a good position for your hand to be in, so it can kind of constrict everything too. And if you feel like you're unstable, your automatic response is to grip tighter on that, and that's all bad for the blood flow to your hand. So yeah, you're right. That's probably, you know, you're telling me it's really that, and that's important. So we always learn to listen to your patient. You're basically telling me the answer, that it is affecting it.
Doctor, do you do one hand at a time, or
Yes.
do you go both?
It's still a big operation, yes.
Okay. And,
If you do operate on both hands, you have to have a really good friend to take care of you afterwards.
my second question was, how long before post-op that you can do normally functioning things like driving a car?
Let's say you have the surgery, no bypass or anything. You have a splint on for the first week or so. Your other hand is completely free, okay? But the splint goes to your fingertips. You come see me a week or so afterwards. We take off the splint. We get you moving with your hand. We make a little plastic splint for you to wear at night. But in the daytime, we want you to start using your hand. And if you have no wound healing problems, you come out by 2.5 weeks to take the stitches out. We're happy to see our therapist really for range of motion exercises to get back your motion, because once your hand is out like this and the patient with scleroderma, they stiffen up pretty quickly. So we want to get you some therapy. But after the first post-operative visit, which is a week to 10 days afterwards, you can wear a glove and even begin to drive or something. You can use your hand, but we don't need to do too much with it. So unlike a lot of other surgeries where we fix a tendon or fix a nerve or fix a bone, we really keep you in a cast. We don't have to do that.
29 years ago, I had carpal tunnel syndrome surgery, and at the same time, I was diagnosed with scleroderma. Is there a relationship between the two?
No. Some patients have both. Like you, some patients have both. if a patient has carpal tunnel at the same time, we would release the carpal tunnel because that's another main reason to have hand pain.
We've got a couple at this table.
Could you talk a little bit about nodes in arthritis versus
Calcinosis?
Yeah.
Nodes, you mean just lumps and bumps that develop?
Yes.
Yeah. There's different rheumatoid arthritis and different types of arthritis. You can have soft tissue collections of the rheumatoid material, and they're softer. The calcinosis, there's two kinds, as you know, it's kind of the toothpaste soft stuff, and then the hard rocks, the pebbles. And so those are two different processes. The nodes usually come on the back of your fingers, and the calcinosis seems to run along the finger course, sometimes along the course of the nerve or artery too. That's why you have to be very careful when you have someone take that out, that they don't willy-nilly just cut out stuff. Because
Can you see the difference in
between a node and a calcinosis?
Between a node, arthritic
calcinosis?
node, and a calcinosis.
Easiest thing is get an X-ray, because the calcinosis is calcium deposits. So you'll see, like I think one of the pictures I showed you, some white up and down, and that's calcinosis. You're welcome.
Yes, sometimes I meet people from Children's Hospital behind me, and there are some scleroderma patients there as young as 5 and teens. And of course, one of the first symptoms they may get is Raynaud's. One of the things I'm concerned about giving this information to them is that they may think of there being, quote, a cure for, their kid's illness. And so I'm afraid that, if I give this information incorrectly, they may get overexcited about this information. So, if you're talking about a 5-year-old or a 16-year-old, they may have something else going on that's cutting off this circulation. Well, can you talk a little bit about that?
Yeah, there's it's a different entity. There have been some cases of called linear scleroderma. People think it happens in kids. I've never seen it in a 5-year-old. I've seen some teenagers. I treat that as a different process at all. So I've never done any of this for kids of that age. I wouldn't even recommend it for that age. Absolutely not. Yeah, because usually they don't have ulcers. They have some Raynaud's symptoms. And again, if patients are coming in with just some symptoms of Raynaud's, a lot of people have Raynaud's. My wife has some Raynaud's. Okay, those patients don't need this operation. It's really patients with scleroderma who have had pain, severe pain and ulcerations that cause problems, or early ulcerations or early changes, or even specific fingers are different and worse than the others. Those are the people that may benefit from this.
Thank you. Could you just clarify something for me? Because I've had primary Raynaud's since I, remember looking at white fingers and saying those are mine. And then, of course, it got worse when diagnosed with scleroderma. It kind of doubled in how bad it was. When I was younger and just had primary, would collagen have been involved in that at all or no?
So when were you diagnosed with scleroderma?
I probably had it for 7 years, although I was diagnosed about 3 years ago.
So maybe the reason you had the Raynaud's was scleroderma all along. We don't know.
Oh, okay.
It's hard to know which comes first. Yeah, and so it may have been less severe at that time, and you maybe had a little early amount of it. With primary Raynaud's, there's not the collagen around the blood vessels. So the surgery would only address the sympathetic supply. And there was actually a nice study by one of my friends in Boston that shows those patients don't necessarily get better because they don't, when you strip off all that collagen, it doesn't make a difference. But specifically in the scleroderma, you're getting a 2-for-1. You're stripping the blood vessels of the nerve supply as well as taking the collagen off. So, you may have had it before, and that may have been like the first notice of anything in scleroderma.
I have a question about fingernails for people that get infections at the tips. And if you go to enough functions over the years, you'll hear one person say one thing. And a couple of years ago, a rheumatologist said, don't ever let someone just take off your fingernails. And I've been in a situation like 8 years ago where I had an infection and you end up in the emergency room, they want to take off your nail. But in the long run, it doesn't really matter, right? I mean, if your nails are taken off, and when we have ulcers and we lose you know, you only end up having a minimal nail. Does the nail serve any purpose, or do you care whether or not when you're doing surgery,
Okay,
you know,
that's
the nails are
a
gone?
really great question, because I didn't touch on that. I'm glad. It's a common question. So let me tell you what a normal nail does. Okay, a normal nail, think again, the root of a tree. It grows from this area here at the base, okay, just proximal to the nail itself. It's called the germinal matrix. That has the capacity to grow a nail, and the nail doesn't grow up, it grows outwards. Okay, it grows outwards like this. And when it grows outwards, it's like landing on a fine runway. The base of the nail, underneath this material called the sterile matrix, is where the nail sits on. And the nail slides out, but also it sticks down to the underlying surface. And that's what a normal nail grows out like that. A couple of things happen with scleroderma. You can have an ulcer on the side of your finger, so that runway has a bunch of rocks and stuff, and it's broken up. So that nail can't grow well and doesn't stick down as well. Okay, and it'll grow crooked and lift up halfway. That happens, bacteria can get underneath the nail edge there, and in that situation, you can get an infection underneath the nail into that germinal matrix, which is very difficult to cure. In that situation, what I do in the operating room is, as I'm doing the surgery, I do take the nail off because I want to make sure that we clean out any source of infection proximal to that. However, usually after that, I slide in a small plastic strip or something underneath the nail fold. If you look at your own proximal nail, it's called a nail fold. The nail grows out from there. If that fold heals down, then the nail can't grow out anymore. So the short answer is, sometimes you do have to take the nail to get to the root of the problem. I don't take it lightly, but sometimes you do have to really treat the infection. And if you have an ulceration that makes me take off part of your finger because it's so bad that it doesn't heal, that nail may never grow perfectly right anymore because the underlying foundation is disrupted. No, but a nail is protective. The reason why we have nails is because we can bang on it like this and not have to bang on the soft tissue. But your nail should grow back.
We have one here. I have a question relative to osteolysis of the fingers. Is there any indication that that is vascular related, and would increasing the flow of blood to the fingers stop the progression?
The reason why you have osteolysis could be because of poor blood flow. It can also be because of kind of underlying infection in that area. And so all those are related, yes. Yes. Was that clear for you, or you seemed? Okay, so with osteolysis, the tips, you're talking about the tips of the bone kind of being resorbs, right? So 3 reasons why that happens. 1 is because the inflammation eats away at it. 2 is because there's not enough blood supply to kind of have bone grow. And the 3rd is without the blood supply, the tips of the finger get infected, and the bacteria can eat away at the tips of the bone.
Now, would the infection show on the surface, or is it only internal?
It may show on the surface and go inside, or it may not. So some people can have osteomyelitis at the tips of their fingers. From some reason, some bacteria got in, and it's very hard to get rid of. So for those 3 reasons, the bacteria and the poor blood supply, yes, that leads to osteolysis. The 3rd one is the inflammation that happens with any kind of connective tissue disease, and that may or may not benefit from any blood supply changes.
I heard you mention earlier about the hand therapy, well, actually during surgery, about not really pulling hard on the hand because it doesn't really help. And I know you gave a talk a few weeks ago. Would you be able to communicate that to the hand therapist as well? I have a really great hand therapist. Let me do
Oh, yeah. Oh.
Hand therapy is amazing.
Yeah.
But there are a few out there who still kind of think old school. I mean, yes, you should pull, but there's a few that pull really way too hard.
Okay.
That was interesting. It was enlightening for me to hear you say that. Whoa, maybe, you know, it's important that everybody's on the same page about how far you push, how far you pull.
Well, okay, let's be clear. What the hand therapists are doing is they're doing, progressive stretches, and if you're hurting, you may want to back off. Okay. I'm talking about in the operating room with the patient asleep and really ripping it apart, more without any feedback from the patient. That doesn't work. Okay, so progressive stretching, progressive splinting can help. Stretching a little bit, if it hurts, you may say, okay, I want to back off a little bit. But in the operating room, it's really wrong to just, I mean, I can take a hammer and really break at it. Obviously, that's the wrong thing to do. So you want patient feedback is real important at that point. Sure.
Do you have any information coming from other countries who have used it more or studied it more?
No, just a few. I mean, again, we're a small, nerdy group of hand surgeons that talk about this. Is what we talk about. I mean, some guys have some experience with just episodic cases of using it. It works for a while. No one knows. That's the one problem insurance companies have is no one knows why it works or doesn't work. The mechanism of why it works is not connected to this, because Botox works on paralyzing little muscles. So why is that changing anything around the blood vessels? Is it decreasing the muscle work so that the muscles don't suck up the blood supply and goes to the fingers? We don't know. And it lasts for a short time. And so it's very hard. We talk about, God, I'd like to try this on the patient, but insurance won't cover it. It's hard to get coverage for it. Well, I've had a couple of patients work. It didn't work on others. So it's definitely not the cure-all for that. You're welcome. Yes?
If you did Botox on my hand, could you switch the needle up?
Or the other way around. You can have someone do it here and put it in your hand, right?
Okay, thank you so much.
It's a real pleasure. Thank you.
Just want to present this to you
Oh,
as a
thank you.
token of our appreciation. So thank you so much.
Thank you. It's a real pleasure. Thank you very much. Thank you. Thank you very much. That's great.
They're just finishing up, getting ready for lunch. Lunch will be served in just a few minutes, and then we'll start promptly around 1 o'clock. And I may do a little speaking to you while we're eating. So please enjoy, go to the restroom, take your time. Occupational therapists and licensed. Sue is a grad